Pathology, introduction to immunosuppression, and we will know some terminology like induction, desensitization, maintenance, treatment of rejection. We have also two studies today. We have the Symphony study and the Transform study, and we will present a clinical practice on immunosuppression in a case scenario, and we will have meet the expert session. Okay, we will start our session by immunology system, which is our army, and this is a picture from the previous session. Our army, and this is our army. We have, I will use a pointer. Okay. We have 5 types of white blood cell. We have 3 types, which is called the granulocytes, which have granules, and it's have already its weapon. And this is called the innate immunity. And we have 2 cells which have no granules, which called the monocyte and the lymphocytes, and it is called the adaptive immunity. This is our immune system. As we mentioned, we have innate immunity for rapid response and contain the granulocytes, which consist of basophil, eosinophil, and neutrophil. And we have the adaptive immunity, which is the antigen-presenting cell and lymphocytes. First of all, we have these types of cells, which is monocyte. Monocytes, it have another name, which is called macrophage, and it's also named antigen-presenting cell. What is the meaning of antigen-presenting cell? She present antigens. So this is the type, the name, the cause of the name. We have kidney. Kidney, it's carry antigen. It's a different antigen from the donor. And we have, this is a macrophage, and we have, this is a T cell. So T cell can detect an antigen, and this is by direct stimulation, direct activation. And as we mentioned in the previous session, this is very strong activation of T cell. And there is indirect pathway. It is done by what is called antigen presenting cell. So this is the antigen presenting cell. They detect the antigen on the graft, and they present it to the T lymphocyte. It can present only a small part from the antigen, and this is called the indirect pathway, and it can present the whole antigen to T cell, and this is called semi-direct pathway. And this is the picture here. Again, we have some cells called the monocyte. It has another name, which is called the macrophage, which is called the antigen presenting cell, and its function is to present antigen. And this is the macrophage, and this is the graft. The graft carry different antigen. The macrophage present the antigens to the T cell to stimulate it, and this is the pathways. We have T lymphocyte, and the first kind we will present here is naive T cell. And as you can detect from the picture, it's just a messenger. It diagnoses the antigen by the antigen presenting cell. This is the antigen presenting cell. This is the naive T cell, which doesn't attack or enter any battle. It just get activated and start to stimulate the immune system. And this is why it's called naive T cell. Naive T cell is stimulated by the antigen presented by antigen presenting cell. So we have antigen presenting cell here, and we have naive T cell on the other side, and it is activated by 3 signals. First signal is the antigen, which is red, presented by the antigen presenting cell, and recognized by T cell receptor. This is the signal 1. Signal 2 is a co-stimulatory signal, which is connection between the antigen presenting cell by what is called P7 and attached to CD28, 28, and it's finally ended by cytokines, which have its function on receptor. So again, in summary, we have antigen presenting cell, which is called here dendritic cell, detect the antigen and present it to the naive T cell. This is the naive T cell, which, as we mentioned, has no information, just stimulates the other immune system. And the cytokines released from the naive T cell to form what is called effector T cells. So we have now effector T cells, which start its function. Okay. And as we mentioned from the previous session, the effector T cells, it's more different groups of soldiers. Every soldier have its function and they have its role in the immune system. This is a summary of the effector T cell. And I want to highlight two types of effector T cells. And from the previous session, this is the effector T cells. This is the antigen presenting cell that diagnosed the antigen and presented it to the naive T cell. Naive T cells secrete the cytokines, and the cytokines stimulate formation of effector T cell and start to stimulate the whole immune system. We have two types, two important types of T effector I wanted to highlight. First one is the T memory, and as we mentioned, after the end of the battle, we should have a memory of this battle, and this memory we should do two copies. One copy it will be central just for the next battle, and the effector memory which will stimulate or start a rapid battle. And the most important type here in this session is the T follicular helper. This is a T follicular helper, and this is its picture. It's an information sender to the B cell. It detects information about the antigen and present it to the B cell by what is called CD40, CD40L, or CD40 154. So this is for the first time now we are talking about the B lymphocyte. B lymphocyte, this is the whole picture now. We have antigen presenting cell. Antigen presenting cell which is called the monocyte or the macrophage. We have the antigen presenting cell, which is macrophage. Detect the antigen and they present it to the T cell. T cell detect it, and now it is now not naive T cell. It's a T follicular helper which stimulates the B lymphocyte. B lymphocyte, it will not be stimulated if this cell not stimulated, and this cell just tell the B cell about the antigen. It passes the antigen to the B cell, which start to form antibody against this specific antigen. So this picture is showing you the B cell, which now knows the antigen from the T follicular helper, which passed the information to it, and now it's know what is the shape and what is the place of this antigen. Okay, so this is our military basis. This is the lymph node or the secondary lymphoid organs, and we have all types of cells, antigen presenting cells and the T cells, and we have the B cells. B cells now know everything about the antigen and start to form its arrows, which is the antibodies. So we have a different cell now, which is the B cell, and I call it the archer. Why this is the B cell? B cell have its B cell receptor, which is the funny part is the antibody, and it's transformed also to the effector B cell, like T cell, which is formed from naive. This is called the naive B cell. Naive B cell, it have nothing, have information, and now it gets the information from the T follicular helper, and she can transform it into plasma cell, which is now effector type of the B cell. This effector type tries to secrete the antibodies. And as we mentioned, as you see in this picture, the B cell, naive T cell, have a CD20, but when it transformed to plasma cell, it lost the CD20 receptor from its surface, And we will use this information in the immunosuppression. Now we have that naive T cell, it has CD20, and there's a plasma cell, which is the effector form of plasma of B cell. It secretes the antibodies and has no CD20 on its surface. This is the summary of the whole immunology. So we have antigen presenting cell, which present antigen to the T cell, T lymphocyte. T lymphocyte is stimulated to the effector type, which is one of them T cytotoxic, and some of T cell it's transformed to T follicular helper, which pass the information to the B lymphocyte, and the B lymphocyte started to secrete the antibodies after it's transformed to what is called plasma cell. This is the whole summary of the immune system. Now we have what is called antibody, and you should carefully know the structure of the antibody. Antibody have two structures, the Fab part, which is the upper part. The upper part here have what is called N terminal, and we have the FC part, and the FC part have what is called C terminal. What is the information? What is the importance of this information? Now you will detect that this is the site of attachment to the antigen. So the antibody secreted in the plasma, he will attach to the antigen by its N terminal, and it will attach to the immunity cell on the other side, which is the C terminal. This is the structure of the antibody. And you should know also the how antibodies is formed. The antibodies is formed by injection antigen in animals and get the antibodies from its serum. First of all, antibodies it was made from mouse, and as you see, it's all black in color. This is from mouse, and when it's used in treatment of patient, it is very antigenic and cause very allergic reaction. And one example of this antibodies from mouse, which is called Octa3, which was very antigenic and stopped from marketing because it's antigenicity. And when they solve this problem, they form what is called chimeric antibody. What is the mean of the chimeric? Chimeric, we have 75% of the structure of the antibody from human, which is white color, and we have just 25% of its structure murine, and this is less antigenic. Finally, we have the humanized, which is 95% from human, and just this small part in black, it's from animal or mouse. And the final part is human, which is totally from the human. This is the types of antibody, murine, chimeric, humanized, and finally the human. We have, you should know that any chimeric antibody, it will end by XCMAP, but the humanized antibody, it will end by ZOMAP. So we have four medication here, what is called daclizumab and basiliximab. ZOMAP, this means this drug is humanized. This means that it will be less antigenic. It will be around 95% of its structure will be humanized. On the other hand, when we have the basiliximab, it's a chimeric. It's a chimeric made 75% of its structure from human and 25 from animal, and it will be more antigenic. And both of them are CD20, anti-CD20-25, so it's the same drug and the same target, but it's different from structure. Also, we have rituximab, XCMAB, that means that it's a chimeric drug. And we have obinutuzumab, which is Gazyva. It's a new drug, and both of them anti-CD20. But this one is chimeric, but this one is humanized. Okay? We will summarize the whole story. We have donor antigen presenting cell, or the antigen presenting cell, which detect a naive and detect the antigen and present it to naive T cell. Naive T cell is stimulated to the effector, and the effector is multiple types, but we have T follicular helper, which stimulate and pass the antigen to the B cell. B cell now it's transformed from the naive form to the plasma cell. Plasma cell now it's secreting the antibody. Antibody can be attached to the graft, and when it's attached to the graft, it's mainly stimulates the complement system. Complement system ending by what is called the membrane attacking complex and cause graft dysfunction and graft damage. This is one pathway. The other pathway is by the, as we mentioned, the antibody have two parts. One part which is called the FC part, and the other part which is the Fab part. Fab part is attached to the graft, and the FC part it will be in the plasma and stimulate all cells to get attached to it to cause a graft damage. So it's the antibody cause damage by two pathways. It can stimulate the complement system, and it's also can attach to the immune cells and stimulate the immunity to destroy the graft. Now we have just 2 minutes to have introduction to nephropathology. If I told you we have a biopsy, and this biopsy have acute cellular rejection, and another one have acute antibody mediated rejection, what do you expect you will find in the graft? Just write in the chat what is your expectation to find in the graft, if this graft showing cellular rejection or this graft showing acute antibody mediated rejection. Write in the chat. I just tell the answers is written. I wish just tell you my imagination. Some of us imagine that cellular rejection, that you will found T cell in the graft. Antibody mediated rejection, that you will find B cell in the graft. B cell and the antibodies in the graft. Is this the reality of the what we see in the graft, or there is another thing you will find? If you know the information, just write in the chat, please. Try to communicate as much as you can. C4D in antibody mediated rejection. Antibody mediated rejection. Excellent, very excellent answers. So I will present just 2 pictures to make you notice the difference. On the right hand, we have antibody mediated rejection in the pathology. On the left side, we have cellular rejection. What is the difference? Just focus. We have here glomerulus, and we have here tubules, and there is the interstitium. We have inflammation in the glomerulus here, and the tubules is normal or healthy. It presents nothing. On the other hand, in this pathology, we have the interstitium followed by polymorphic neutrophils, and we have severe tubulitis. So if I told you that we have, this is on the right side is the antibody mediated rejection, and on the left side, this is the T cell mediated or cellular rejection. How this happen? I will again present the whole summary, and you will notice we have T cell, which stimulate the P cell, and P cell just secrete antibodies. It doesn't need to go to the site of pattern. It just send an arrows to the pathology, and this is why you can't detect the antibodies, the B cell, and you should search for the antibodies. So If we have antibody-mediated rejection, you expect to find the complement pathway in the pathology, or you may find these cells attached to the Fc receptor of the antibody and cause a kidney damage. That's why in the pathology, if you told that the pathology show acute antibody-mediated rejection, you expect antibodies just reach to the glomerulus and the peritubular capillaries and cause what is called glomerulitis and peritubular capillaritis. Also, you should search for the antibody in the serum, and this is why we search for DSAs in the serum, and this is HLA and non-HLA, and I wanted to highlight what is called post-transplant cross-match CDC-DDT. What I mean by this term, if a patient have acute antibody-mediated rejection, so this means his B cell formed antibodies. So if we do again, if we repeat the cross-match CDC, which was negative before transplantation, it will become positive. And this is some modality of the cross-match, not for screening before transplantation, it's for detection antibodies in the antibody-mediated rejection, and it's called post-transplant cross-match CDC-DDT. Also, we search for C4D in the pathology, which is the end product of complement activation. And in the final, we should do what is called genetic expression, which look for the transcription of the genes in the graft. Okay? So if we compare T cell mediated rejection versus antibody mediated rejection in the graft, this is the summary. In the cellular rejection, you will find the tubulitis and severe interstitial nephritis. But on the acute antibody-mediated rejection, you will find what is called glomerulitis and peritubular capillaritis. And the main difference between the cellular rejection and the antibody-mediated rejection is the presence of the antibodies. Antibodies will attack or stimulate the complement system, and it will cause C4T staining in the graft in the antibody-mediated rejection, but this will not happen in the cellular rejection. Also, you will have a DSAs or a post-transplant positive cross-match in the antibody-mediated rejection, and it will be negative in the cellular rejection because cross-match and DSAs are looking for antibodies in the serum. Okay. Again, I will show you the picture from the pathology. On the right side, there is a glomerulitis and the peritubular capillaritis. This is the antibody-mediated rejection. And on the left side, you will find a severe interstitial nephritis and tubulitis, what is called T-cell mediated rejection. And this is from BAMF classification. I just put the picture. This is not our topic today. We will proceed for medications. What is the best site of for immunosuppression? This is the whole picture, as we mentioned in previously. We have antigen presenting cell, we have naive T cell, which is stimulated to effectors T cell, and the B cell, which is stimulated to plasma cell, and the plasma cell secrete antibodies. Antibodies do its action by complement and complement non-binding DSA. What is the best site for immunosuppression? What do you expect? Just write on the chat. What is your imagination? What is the best site for starting immunosuppression? Okay, antigen presenting cell T cell inhibition. Of course, it will start by T cell stimulation. If you inhibit the T cell stimulation and what is of T cell, what is called naive T cell. If you inhibit this naive T cell to pass this information about the graft, so you will not have cellular rejection. And by mean, it will inhibit the plasma B cell stimulation.
وياد خلص مذاكرة يا أدهم؟
This is, can we mute the sound, please? Okay. This is the naive T cell. As we mentioned before, naive T cell have two stimulation signals to be transformed to the effector, and we have one kind of the effector which is called T follicular helper, which stimulates the B cell to transform it to plasma cell. This is the three signals. We have here antigen presenting cell presenting the antigen, and this is the attachment to the T cell, which is called CD3, and this is co-stimulatory signal, and we have the signal 3. I will just summarize the signals roughly. We have the red color is the receptor on the T cell. In the black color, it will be the antigen presenting cell. So first of all, we have what is called CD3. CD3, it's present. It's apart from T cell receptor, and it is attached to the antigen, which is presented by antigen presenting cell. This stimulates a special kind of messengers, which is called calcineurin. And the calcineurin stimulate DNA transcription. We have two signals in the DNA. What is the nuclear factor of activated T cell? And after this stimulation, this is signal 1. We have now signal 2. Signal 2, we have CD28. This is on the T cell, and B7 on the antigen presenting cell. And you should know that B7, it has also another name, which is called CD80 and CD86. But simply, just to remember, it'll be for B. B7, it's on antigen presenting cell, and it's attached to CD28 on the T cell. And the signal 3, which is the interleukin secreted and act on its receptor, which is CD28. And this stimulates what is called the mTOR signal, and still the cell starts to divide, and this is the anti-metabolite. And just to remember and not to forget, if you subtract 28 from 3, it will be 25. So we have CD3, CD28, CD25. It's simple to be remembered. And you have connection between CD28 and B7. And to make sure to remember, B for B. B7, it's present on antigen presenting cell. Okay? This is a 3 signal. Also, we have what is called the CD52 on the T cell. And we have the CD40L, which is a connection between the T cell and B cell. This is the immunosuppression for naive T cell. This is the picture, the familiar picture from all lectures. We have the antigen. This is the antigen presenting cell, and this is the T cell. The antigen is presented by the monocyte or macrophage or the antigen presenting cell here. And it is being recognized by what is called CD3. CD3, it's apart from T cell receptor in the T cell. And this will stimulate the calcineurin signal, and the calcineurin signal will stimulate the DNA transcription, nuclear factor of activated T cell, and the nuclear factor kappa. And we have the signal 2, which is called CD28 on the T cell, which connected to CD80, what is called also B7. Finally, the interleukin will be secreted and attached to its receptor, which is called CD24. So we have CD20.
لو في حد عندكم في سماعة تحب تسرقها لي من أي حد هاتها لي.
اديكي سماعة الطيارة.
ماشي. شغالة برضه مش وحشة.
هي حلوة حلوة.
هاتها لي.
اهي.
Okay. Okay. Again, we have here the CD20, the interleukin, which act on its receptor, which is called CD28, 25, and we have the mTOR signal and the metabolism of the cells to start to proliferate. So this is the side of drugs. We have the calcineurin inhibitor, which is signal 1. And we have anti-CD3, which was as an octa-3 and was removed from the market, and it's signal 1 also inhibitor. We have the drug what is called belatacept. Belatacept is inhibition of CD28, which is the costimulatory signal, which is signal 2. And we have anti-CD154. We have also the anti-25, CD25, and we have 2 drugs in the market. We have the daclizumab, which is humanized, and we have the basiliximab, Simulect, which is Symphony. And we have the drugs which act on the mTOR signal, which is mTOR, which contains the sirolimus and the everolimus, and or the drugs which act on the cell proliferation and the metabolism, which is called Azathioprine and MMF. Some drugs like JAK inhibitor was in the market and was also removed because of the side effect. And we have anti-CD52, which is almetuzumab, the campus, and we will mention in the next slide. So these drugs, all drugs act on naive T cell. None of them act on the B cell. So if we decide to give medication against the B cell, this is not our options. The target cells target therapy against the B cell is shown by this diagram. We have here the T cell. T cell presents the information to the B cell. B cell started to transform it to the plasma cell. The plasma cell is secreting antibodies, and the antibodies is started to attack. So if we need to target the B cell, we need to give what is called anti-CD20, which is rituximab and obinutuzumab, as we mentioned, Gazyva. And if we decide to attack the plasma cell, we have what is called bortezomib. Bortezomib is a drug for multiple myeloma. And it's failed in the sector of transplantation. This is a study we will mention in another situation. And we have the IVIG and the plasma exchange for removing the antibody from the circulation. And we have a new drug what's called ICE. This is not our topic now. So we have drugs against the B cell, which is anti-CD20. We have drugs against the plasma cell, which is the bortezomib. And we have drugs against the antibody, and the drugs act on the membrane attacking complex like the eculizumab. This is a diagram about rituximab. Iximab, as we mentioned, it's a chimeric drug. 75 of its structure is human, and 25 of its structure LP murine. It's a depleting, which is cause depletion of the B cell, and the monoclonal because it's a function only for B cell. This is the B cell, and this is the rituximab. Rituximab attached to the B cell and stimulates the complement-dependent cytotoxicity, and which is aimed by B cell apoptosis. So it's a depleting, causing destruction of the B cell, and it's only monoclonal because it's function only on B cell. It has no effect on plasma cell because plasma cell has no CD20, and this is the site of action of the rituximab. And also it have no function on the T cell. So finally, we have this patient. He decided to be a recipient, and this is his donor. And he asking you to transplant him. What is your decision about the immunosuppression clinically approach? First of all, you should decide what is your immunological risk. You should divide your recipient into 3 categories. First of all, low risk patient, moderate risk patient, high risk patient. This is depend on multiple criteria like matching. What about his matching? This is number 1. What about antibodies? Cross-match CDC negative, cross-match flow cytometry negative, and BRA is negative, no DSAs. This is a low-risk patient. Low-risk patient, he will be good match, no antibodies, negative cross-match, and the negative DSAs. So it's low-risk patient. Moderate risk patient, the patient have poor cross-match, patient have low titer DSAs, patient have primary kidney disease, glomerulonephritis like lupus, it will be moderate risk. High risk patient have DSAs, have positive cross-match by flow cytometry or even DSAs with high titer. This is a high risk patient, or a patient have poor matching. This is some terminology you should know. We have what is called desensitization. What do you imagine about desensitization? Desensitization, that means this patient is sensitized. What is the meaning of sensitized? He have antibodies against the donor. So we have a problem here. This patient have antibodies against his donor. So if I need to treat him, I should give him medications against B cell or T cell. Desensitization is mainly treatment for antibodies. So the treatment will be mainly for B cell. Induction, this means this patient is going to the operation and I need to give him a heavy immunosuppression just to induction and prepare the body for the graft. So what is the target of my medication? What you expect from induction? Induction, it will be mainly directed to the T cell. Finally, we have maintenance. What is the mean of maintenance? That means I need to give this patient immunosuppression to maintain his immunological status and to make sure that the kidney, it will not be rejected. And what is the target of the maintenance therapy? It will mainly for the T cell also. Finally, if the patient have a rejection, what is the treatment of this rejection? It will depend on T cell or P cell. It will depend on both of them because we have two kinds of rejection, T cell mediated rejection and P cell mediated rejection. If we have T cell mediated rejection, it will be the therapy will be for the T cell only. But if we have P cell rejection, it will be for both. So again, we have this patient and you need to write immunosuppression for him. So firstly, you will decide if this patient is low risk, intermediate risk, or high risk. And you will proceed for the treatment. This is simply, it's the treatment for rejection. And if you noticed, the red color is for the T cell and the black color for the B cell. And because we have two types of rejection, T cell mediated rejection and B cell mediated rejection. On the other hand, if you decide to desensitize the patient, desensitize, that means you are targeting the B cell. So if you just noticed plasma exchange, IVIG, rituximab, bortezomib, splenectomy, this is all targeting is B cell, because desensitization, it's mean we're removing the antibody and the antibody is the arm of B cell. Finally, the immunosuppression medication, as we mentioned, we have induction, and the induction is mainly for naive T cell. You induct the patient and give him heavy immunosuppression as preparing his body to receive the graft. And this is the medication used in induction, which is corticosteroids, ETG, interleukin-2 receptor antagonist, which is basiliximab, and finally anti-CD25, which is almituzumab. On the other hand, the maintenance therapy, the drugs to maintain the immunological status, which include corticosteroid, CNI, mTORs, and antimetabolites, which is azathioprine and MMF. This is a question. I have a short time, so I will just enumerate the slides. Why the induction is restricted? Why, if we can give all the patient heavy immunosuppression, and we prepare the body of the recipient to receive the graft, and there will not be a rejection. This is the result of induction. We use what is called ATG, what is also called the polyclonal antibody, and sometimes we'll use the interleukin-2 receptor, which is called the paclitaxel. The difference between the two kinds of induction is this is depleting. It causes destruction of all T cell and B cell. Interleukin-2 receptor, which is anti-CD25, it's only receptor blocker. It doesn't cause depletion. This is so you can imagine this is a weak drug and this is very strong drug, but because it is very strong, it increase the risk of infection and malignancy. So most of patients received ATG, they are very exposed to cytomegalovirus and more opportunistic infection, and more common to be get malignancy. On the other hand, in interleukin-2, it's very weak drug. It have very weak induction properties, but it has very low risk of infection and malignancies. So not all patients receive induction. You should put in mind when you decide to make heavy induction by some medication like ATG or paclitaxel, there is a risk of infection or malignancy. And if you found this is the main target of treatment or induction is the T cell. This is the balance you should put in mind. Some patients die because of immunosuppression. This is a heavy equation, and you should put in mind not to lose the patient. This is the most important thing. If you give a heavy immunosuppression, you will kill the patient by infection and malignancy. And if you have a loose hand and give him suboptimum immunosuppression, you will lose the graft. This is the history of immunosuppression. I will summarize rapidly. First of all, we have corticosteroids in 1960, and then Azathioprine was created in early 60s. So any transplantation at this time was made by dual immunosuppression, which was corticosteroids and azathioprine, and this was associated with around 75% rejection. If we do a 100 graft, you will lose 75 of them by rejection using these two lines of immunosuppression. And then finally, we have the polyclonal ATG for induction, and the revolution in the history of transplantation was the cyclosporine. Cyclosporine was CNI, and CNI is a signal one. So it's very potent drugs. It inhibits the calcineurin. So there is no interleukin-2, and there is no stimulation of naive T cell, and there is no stimulation of the B cell. And this is was the revolution in the transplantation. We have the Octa3, which was removed from the marketing because of its allergic reaction. And we have the tacrolimus in the early 90s. And we have also the sirolimus and the basiliximab at the late of 90s. So we have a multiple immunosuppression, and this stimulates us to do a study to detect which one of them is better from the other. And this is the Symphony study. Symphony study was made to decide what is the best maintenance therapy. And they made 4 arms of patient. One arm receive high dose of cyclosporine. This is the first arm. The second arm receive induction by what is called the daclizumab, which is like paclitaxel, anti-CD25, and receive low dose tacrolimus. And the third arm it was inducted by also daclizumab was low dose cyclosporine, and finally induction also and sirolimus. So we have 4 arms. Number 1, high dose cyclosporine without induction. Number 2, we have arm induction and low dose tacrolimus, and we have another arm induction or low dose cyclosporine, and finally we have induction and sirolimus. What do you think the result of this study? The result of this study, according to the graft survival and rejection, the best result was in the arm of induction and tacrolimus low dose. So the graft survival and rejection, the rejection was around 15%. Just 15% rejection in the arm who received induction, non-depleting induction by daclizumab, and small dose tacrolimus. And the next best result was related to the induction and low dose cyclosporine, which was also CNI, and the rejection was around 25%. And the next best result was the high dose cyclosporine, and the rejection was 24%. And the last and the most bad result was the arm who received the induction and the sirolimus, which is M2, and the rejection was 37%. So if you focused in the result, you will detect that CNI is the most important and the cornerstone for treatment of immunosuppression. And this is the two kind of form in the marketing, which is Prograf and Neural. And the Prograf was called in the first FK. This is the scientific, the experimental name. This is why some doctors write FK, FK, FK. This is the experimental name, and the scientific name is tacrolimus, and the trade name is Prograf. Neural, also it's cyclosporine. This is the CNI signal 1. And this is a very important diagram because these drugs have a very therapeutic index and have very high toxicity. So you should know this diagram carefully, because this is how we monitor this drug. We give the drug. This is the time of taking the drug. And with the drug have its maximum level, which will be around 2 hours after taking the drug. And it will decrease until the next dose, which is the trough level, which is the lowest concentration in the blood. This is the trough level. What is the mean of trough level? The blood concentration of this drug before the next dose. What is the mean of Cmax or C2? This is the concentration of the drugs after 2 hours of its intake, and this is the highest concentration. Why we do this? We do this because we should know that this is the area under the curve. What is mean the overall drug exposure? And if we have very small area under the curve, this means this patient will not be covered by immunosuppression, and the kidney will be rejected. This is simply the diagram of pharmacokinetics. I think we have short of time because Dr. Ahmed Sisi will come after 5 minutes. I will just proceed, and when he starts his session, we will stop and he will continue with us his expertime. Finally, CNI, we have 2 drugs. We have the FK, which is called tacrolimus. How we can prescribe tacrolimus? We can prescribe tacrolimus. We have, for example, a patient 100 kilogram. Its dose it's 0.1 to 0.2 milligram per kg. So if we decide to transplant a patient and this patient is 100 kilogram, Prograf dose is dependent on weight. So you should know your weight of the patient. The dose is 0.1 to 0.8, or 0.1 to 0.2. So we have to give this patient 10 capsule from 1 milligram to 20 capsule. Okay, so again, you have very large dose. If you decide to give the patient 0.1, so you decide to give him 10 capsules, and you will divide the dose into 2 doses, 5 capsule at the morning and 5 capsule at the night. And the difference, the gap between the 2 doses, it will be 12 hours. 12 hours only, because the bioavailability of this drug. But if you decide to give him the largest dose, which is 0.2, you will give him a 20 capsule, which will be 10 capsule at the morning and 10 capsule at the night, which is very large dose. And we usually do this if the patient doesn't receive induction. So if we doesn't give induction, we give the patient 20 capsule. But if we give induction and we are have a safety from rejection by ETG or simulate, so we just give 10 capsule. At the end, these drugs have very therapeutic index, and we need to do a follow-up. Follow-up of tacrolimus is done by trough level. What is the mean of trough level? As we mentioned, we just make the patient to go to the laboratory and take a sample of the blood of the drug concentration just half an hour before the next dose. This is the lowest concentration in the blood, and we just write to the patient to do a trough level for FK. Finally, we have what is called the cytochrome B450, 450. This is the enzyme responsible for metabolism and breakdown of the FK. This enzyme is affected by multiple drugs. This is advantage and disadvantage. Advantage because if we give the patient a drug inhibits this enzyme, we will able to give him a very small dose of this expensive drug. Disadvantage because a lot of drugs cause in drug inhibition or stimulation, and this will affect the level of the drug in the blood, and this may expose the patient to toxicity or rejection. What is the frequency of follow-up? If you just write tacrolimus to a patient, when you ask to do a trough level, firstly, we will do twice weekly after transplantation, because this drug has a lipid lipophilic effect. So it will building up. So you need to do more frequent monitoring. But after few months or few years after transplantation, you do it at monthly or 3 months basis. Side effect, we will discuss the whole immunosuppression in a session with Professor Ali Shendi. He will present us the whole immunosuppression. This is just introduction today. The side effect, we will notice that CNI have nephrotoxicity, so we have to have a substitute for CNI because it's side effects. Also, we have the cyclosporin, which is another member of calcineurin. This member, what is called neural or sandimmune, its dose from 4 milligram to 6 milligram per kg. So if we have patient 100 kilogram, so you should give him 400 to 600, divided into also 2 doses, 200 at the morning, 200 at the evening. The gap between the 2 doses, it will be 12 hours. And the frequency also, follow-up is also used by 2 mechanisms. Cyclosporin, you should do the trough level and the C2, because this have impact on the area under the curve. And also it's affected by cytochrome B450. Follow-up frequency, as we mentioned, at the first of transplantation, we do multiple follow-up. We do twice weekly, and we will make it monthly after the first year. Side effect of the CNI have the same side effect of tacrolimus, but it have some difference, mild difference. This is the CNI cytotoxicity. If you just focused, it have acute insult on the kidney, which will affect the glomeruli, arterioles, and the tubular interstitium. Also chronic insult on the kidney, which affect also the glomeruli and the arterioles and the tubular interstitium. And this stimulates us to have a solution for this, and this is the solution. We decide to give patient form of CNI avoidance, CNI early withdrawal, CNI minimization, and giving some drugs to inhibit cytochrome B450 to be able to decrease the doses. The CNI avoidance, it failed because the CNI is the cornerstone for transplantation because it's signal 1. CNI withdrawal also failed. Finally, the CNI minimization, and this is the transform study. What is the transform study? We have 2 arms. Arm received everolimus with CNI. The Symphony study, it was comparing everolimus against the CNI. This is why everolimus was failing, because everolimus and the MMF, it's the same signal 3. But in the transform study, they use everolimus with CNI. So we give tacrolimus with everolimus. And this is can be done, and this advantage of this regimen is to decrease the dose of tacrolimus and or cyclosporine. The result of this study, after 1 year, it was comparable. The result of the arm of everolimus was the same of the arm with the arm of the MMF, and this is the result of kidney acute rejection and de novo antibodies. But what is the most important is the result of viral infection, which was lowered with the arm of everolimus because it has its antiviral effect. This is the conclusion. The conclusion of transform study, that you can use everolimus, and if you decide to use everolimus, you will expose the patient to low dose of CNI, and this is the main point of transform study. And this is the difference between the complication of cyclosporine and the tacrolimus. And if you read it, this is hypertension, neurotoxicity, and the hair loss, this blah blah blah. The most common side effect for conversion is this, cosmetics, because the patient who receive cyclosporine have gingival hyperplasia. So we transform patient on cyclosporine mainly for cosmetic issues. I will stop my session for now because we have Professor Ahmed Al-Sisi. I don't know if he just, we can start write the questions. We will start to write the question, preparing because he will be with us. And this is, I will highlight rapidly. Professor Ahmed Al-Sisi is controlling the screen. دكتور أحمد حضرتك معانا؟ دكتور أحمد. طبعا at the start I would like to present Professor Ahmed Al-Sisi. Professor Ahmed Al-Sisi, he is a professor of nephrology and transplantation in the National Institute for Urology and Nephrology. He is my mentor at the first, and he is one of the most famous nephrologists in Egypt and worldwide. And it's a very big honor to be with us today. Professor Ahmed Al-Sisi. دكتور أحمد، الصوت بقى لسه مش واضح يا دكتور أحمد. الصوت بس من ايوه بالظبط كده. حضرتك معانا دلوقتي. هخش بسرعه بس لاخر المحاضره عشان انهي ده. فاينلي اجنده. This is it. دكتور احمد ازي حضرتك؟ اخبارك ايه؟ الصوت مش واضح برضه يا دكتور احمد، معلش الصوت عند حضرتك مشكله تقريبا. الو. هيضرب. اوكي ثانية واحدة. دكتور احمد السيسي معمول اميوت. هو اصلا معمول اميوت تقريبا، مشكلة في السماعات او في الساوند. اوكي معاك. Until we solve this technical issue, this is the picture of our Professor Hussein Shaisha. He have a great message. He always convinced that learning is life, and this is true because he spent all his life teaching us, and he is one of our great professors, and we have a great loss. So I will ask all of us to ندعي له، لأنه هو فعلا صاحب أثر كبير في حياتنا كلنا. ربنا يرحمه، ويا ريت إن هيبقى الموضوع ده رسالة لينا كلنا، موضوع إن التعليم ده حياة. لغاية أحمد معانا. اوكي سوبر. الو ماشي اوكي. لا براحتك خالص، براحتك خالص، احنا عندنا وقت. اوكي. طبعا انا كان نفسي اخلص الاجنده بتاعت النهارده، بس لاج اوف تايم بقى، انا حاولت اجري حتى في الاخر، معلش. بس احنا ممكن نحضر بس الاسئله مؤقتا لغايه ما الدكتور احمد يبقى معانا. ممكن نحضر الاسئله لو امكن. الكويشنز ممكن نكتبها في الشات بعد اذنكم. questions. Can we write our questions, please? What is the rule of platacept? This is the first one. What is the rule of platacept? Okay. Okay. This is a question in the medication. What is the rule of platacept? Okay. What is else? What is the frequency of ATG use? This is a very smart question. Frequency of ATG use. Okay. How to treat CNI? Very difficult question. How to treat CNI-induced TMA? CNI-induced TMA. Okay. How we use CNI after TMA? What is the maximum dose per life? ATG also. So we have two questions about ATG. What is the maximum dose, and what is the frequency of using? And we have two questions about CNI-induced TMA. How can we treat, and how can we use CNI after TMA? Difference between everolimus and sirolimus, pharmacokinetics. Okay. This is about ImmTools, and comparison between everolimus and sirolimus, pharmacokinetics with CNI. Okay. Okay, with CNI. Your experience in non-HLA matched transplantation. Okay. Everolimus can be given in immediate post-transplantation period. as shown in one study, how to switch from sirolimus and to sirolimus and everolimus, and this is a very nice question from Dr. Ahmed Taysir. Okay, everolimus can be given in immediate post-transplantation period. How to switch to sirolimus and everolimus in patient with COVID-19 can be used everolimus following the infection. Can't given sirolimus as because import healing CDC negative flow cytokines positive regarding self-antigen PRE. This is a very nice question, Dr. Ahmed al-Sheikh. Self-antigen. Okay, we have multiple questions, very nice questions, and we will have a very nice discussion, inshallah. Okay. Okay, and is induction therapy affect maintenance therapy type and dose? Okay, very nice question from Dr. Jamila. Is induction therapy affect maintenance therapy type and dose? Okay. We can wait or can first precaution and steps regarding. Okay. 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 Until Dr. Ahmed Sisi is here, I would like to do a simple comparison between the azathioprine and MMF. Why MMF is better than azathioprine? This is a question. Why MMF is better than azathioprine? Azathioprine is a purine-based analog, but Mycophenolate Movitile, it's specific, is inhibitory drug that inhibit a specific pathway. This pathway is present only in the lymphocytes. So it's a very specific drug, and it avoids the systemic side effect of azathioprine. And this is why we like MMF over the azathioprine. But this is the area under the curve for MMF, so it is difficult to be monitored. And some patients have anomaly in the another pathway for sensing of guanine base, and they suffer from heavy leukopenia if they receive MMF. So usually we don't follow up MMF, but in some patients we will find that they suffer from leukopenia, severe leukopenia, and they may get advantage from doing an area under the curve for this patient. Also, the dose of azathioprine, it's too easy. It's around 2 milligram per kg, and the most common mistake in prescription of azathioprine when you divide the dose. Azathioprine is long-acting drug, and it's take once-ly. So if you have a female patient mostly receive azathioprine if she decides to get pregnant, because azathioprine is safe in pregnancy. On the other hand, MMF is not safe in pregnancy. So you just calculate its dose. If she is 100 kilogram, you just give it 200 milligram of azathioprine in urine in one dose. Don't divide the dose of azathioprine because it's a long-acting drug. Doesn't need dividing every 12 hours. On the other hand, the other medication need to be divided, and we follow up these drugs only by CBC. There is no drug level because as we see, the area under the curve is very difficult to be summarized. We have the mTORs finally. We have the mTORs, which is certican and rapamune, everolimus, and sirolimus. Usually, we not use this drug, as we mentioned, because they are very weak drugs. But sometimes we need to use it because it's have antiviral and anti-malignancy effect. But we need to do a risk assessment because if your patient is high risk, you may lose the graft if you transformed CNI to mTORs, but it can be used as transform study in together to decrease the dose of CNI. And how to shift or to add mTORs, because this is one of the questions in the chat. We usually know that they are weaker, so mostly we need a biopsy before this shift from CNI to mTORs. Also, it causes proteinuria. So before writing certican or rapamune, you should do 24-hour neuroprotein. And if there is a heavy proteinuria, more than 800, you can't write these drugs. This is number one. Number two, these drugs affect GFR. So if the patient have GFR below 30, you can't use this drug also. So if you have a patient need to shift from CNI to mTORs, you should make sure that the patient has no rejection. So it's better to do a biopsy. You should do a 24-hour neuroprotein, and you should calculate GFR, and you should do a lipid profile because it's associated with hyperlipidemia. If the patient have proteinuria more than 800 or GFR plus 30, and the patient have severe hyperlipidemia, it's mostly to not use these drugs. We have two drugs in the market. We have the sirolimus, which is rapamune. Rapamune is given once. It has loading dose around 5 milligram for 3 days, then 1 milligram per day, and you do trough level. Also, it needs follow-up, so you need to do a trough level. And finally, you have the everolimus, which is a certican. Its dose is loading 1.5 twice daily for 3 to 5 days, then start to give 75%, 0.75, and follow up the dose by also the FK level. We have the immunosuppression, and the immunosuppression, as we know, the cornerstone is steroids. Steroids is main cornerstone in the treatment of immunosuppression because it have the whole signals affection. It affects signal 1 and affects signal 2 and affects signal 3. They inhibit T-cell detection and block the link between the T-cell and the antigen-presenting cell, also block the cytokines and inhibit the interleukin 1, 2, 3, and it inhibits the whole process. The steroid regimen, we have multiple uses of steroid in the immunosuppression. We have it as an induction. We have it as a maintenance. We have it as treatment of rejection. And most of us giving from half gram to 1 gram as an induction, and then decrease the dose of steroids during hospital admission to around 250 milligram per day. Then discharge the patient on around 20 milligram until the first year. Then we decrease the dose of corticosteroid. There is multiple regimen. Corticosteroids is the most important side effect, which is called cause post-transplant diabetes and osteoporosis. So multiple regimens started to avoid corticosteroid, and the result was very bad. So steroids avoidance, it's very difficult, and the result of steroid avoidance is very common rejection, and there is no benefit on the diabetes or osteoporosis except in the transplantation in pediatric, which get benefit from corticosteroid avoidance or decrease in the arm of bone. This is, was the case scenario of today. If we have male patient, 50 years, he have 5 mismatch. CDC DDT is negative, flow cytometry is negative, and you did a PRA, calculated PRA, class 1 was 30%, and the class 2 was 70%, but virtual cross match show no DSAs, primary kidney disease is non-steroidal abuse, and his weight is 100 kilogram. So first you should decide his immunological risk. He has 5 mismatch, so matching is not good, but he have CDC negative, flow cytometry negative, PRA class 1 and class 2, a very significant figure, but no DSAs. So risk assessment, he will be a moderate risk because he has also high PRA, but not DSA. On matching is not good. Desensitization, this patient need desensitization? The answer is no, because his cross match is negative. All of the types of cross match is negative by CDC, flow cytometry, and also PRA. Virtual cross match is negative. He has no DSA, so no need for desensitization. Does he need induction? Yes, he needs induction because he is a moderate risk. So he may get benefit from the induction. We will do an induction by ETG. Most of us will do an induction by basiliximab, which non-depleting induction. And the maintenance immunosuppression will be the conventional triple, Cellcept, Prograf, steroid, Prograf, which is CNI, and you will give him, as you give an induction, so you will decrease the starting dose of the Prograf, which will be 10 milligram, divided into 2 doses, 5 milligram at morning and 5 milligram at night. Cellcept, it will be 1 gram at morning and 1 gram at night, because and there is no follow-up for Cellcept concentration level, because it's very difficult, and just will monitor the patient by doing CBC and looking to the lymphocyte, the white blood cell count. Steroids, we will start by induction in steroids, and we will decrease the dose, and we will discharge the patient from the hospital mostly on 20 milligram, and he will continue on 20 milligram for the first year. I will just focus that all patients receive induction. They must receive CMV prophylactic, because as we mentioned, especially in the depleting arm, when you use ETG, you should give CMV prophylactic. Summary of laboratory investigation: we have basic investigation. We just do it for all patients who did transplantation. We just do CBC, serum creatinine, and Prograf trough level, and this is the routine. CBC, you just look for the hemoglobin, you look for the white blood cell, the creatinine for the early marker for rejection or graft dysfunction. Prograf trough level, because as we mentioned, he has very therapeutic index, and the trough level, it will be different from according to 2 parameters. Number 1, if the patient receive induction, so you will have the relief to give him a very low dose. So the first year your trough level, you will be around from 7 to 10. But if the patient didn't receive induction, you will make the trough level on the higher. It will be from 10 to 12 just for the first 3 months. And then from 7 to 10, the rest of first year. Then the trough level will be from 5 to 7. You will do a urine analysis. Extra, if you decide to put mTORs, you should monitor the proteinuria, and you should do a lipid profile, and etc. Finally, we have, this is the patient. We evaluate the risk. We decide to give him a conventional triple. Conventional triple, what does mean? CNI, MMF, and steroids. This is the conventional. What is the mean of conventional quadruple? This means you will give induction and the conventional triple. quadruple, this means you give induction. Triple, you didn't give induction. This is according to the evaluation of the risk. Monitoring, we have basic monitoring labs, we have extra, and we sometimes we decide to transform from line to line according to the situation. If you have viral, you have malignancies, and etc. And this was our agenda today. We just presented the summary of immunology, antigen presenting cell, which is monocyte, T cell, B cell, which is the antibody structure, nomination, and the mechanism of action. Introduction to pathology. Introduction to pathology. Introduction to immunosuppression medication. Terminology. Now we know all what is the meaning of induction, desensitization, maintenance therapy, treatment of rejection. We know about the Symphony study and the transform study. We get a case scenario. We should have the meet the expert session for Dr. Ahmed Sisi. You're just waiting. We can ممكن نفتح الصوت اللي حد لو في حد عايز يتكلم او عايز يقول حاجه ممكن نتشاور فيها مؤقتا لغايه ما الدكتور احمد ما يبقى معانا. وانا هحاول اكلمه ثانيه واحده. الو. اوكي الدكتور احمد معانا اهو. بسم الله الرحمن الرحيم. برضه اميوت بس المشكله في الصوت لسه موجود. لا لسه موجوده يا دكتور احمد. مشكله الصوت مش لسه موجوده.